Regarding the acromioclavicular joint, the stabilizers, it basically is a diarthrodial synovial joint with a fibrocartilage interarticular disc. Stabilizers can be dynamic and static. Dynamic is deltoid and trapezius. Static is acromioclavicular joint, coracoclavicular joint, deltotrapezial fascia, and capsule. Regarding the acromioclavicular joint, this gives horizontal stability. This means anterior-posterior stability is given by acromioclavicular joint. Coracoclavicular joint consists of trapezoid and conoid ligaments. The trapezoid ligament inserts 3 cm from the lateral end of clavicle, and it is trapezial or triangular. It gives some horizontal stability and a vertical stability as well. Regarding the conoid ligament, more important ligament inserts 4.5 centimeter from the lateral end of clavicle, and it is a vertical stabilizer. Others are deltotrapezial fascia and capsules, which are also important in multidirectional instability, especially vertical instability. So AC joint is for EP direction stability, and coracoclavicular joint are superior inferior stability of the AC joint. Regarding the classification, it's a Rockwood classification, which explains type 1 is AC joint sprain, type 2 is sublux AC joint with intact coracoclavicular ligaments, type 3 is dislocated AC joint with disrupted coracoclavicular ligaments. In type 3, it is nearly 100%. Type 4 is a superior and posterior dislocation. Deltotrapezial fascia is involved. Type 5 is a dislocation with 100 to 300% separation. And type 6 is infracoracoid. Regarding the radiograph, I would like to know a radiograph which is both a bilateral AP view and compare the distance of the top of the coracoid to the bottom of the clavicle on the contralateral space side. Zanka view is a cephalic tilt. So the camera is tilting down and taking a picture from up. So 10-degree cephalic tilt and 50-degree penetration improve visualization of AC joint by eliminating overlying structures. I will now do axillary view to check the posterior displacement. Regarding the treatment for type 1, type 2, type 3 injuries, the treatment is with a sling for 3 weeks and then return to activities within 12 weeks. Surgical treatment is not better than non-operative as per Spencer et al. Higher complication and longer recovery to return to sports. In children, there is a sleeve fracture which looks like type 3, but both AC and CC joint are attached to the periosteal sleeve. 4, 5, and 6 needs operative intervention. And also type 3 injuries in laborious and elite sports, they can go for operative intervention. Current literature shows more than 100 different types of techniques. This include primary repair of CC joints, CC ligaments, augmentation with autologous tissue like coracoacromial ligament, augmentation with absorbable and non-absorbable sutures or synthetic material, or CC stabilization with metallic screw known as Bosworth screw. The 6 basic operative techniques consist of: number 1, AC ligament repair; number 2, dynamic muscle transfer; number 3, coracoacromial ligament transfer; number 4, CC ligament repair; number 5, distal clavicular excision with CC reconstruction and anatomical reconstruction of CC joints. In acute settings, I would like to do something which can improve the healing of the primary native coracoclavicular ligaments. This might be consisting of a screw, or nowadays with a dog point or endo button. The primary aim of this is for the healing of those ligaments. The second option would be to have a LARS, which can be utilized to recreate and reconstruct the conoid coracoclavicular ligaments. And the fourth option would be to transfer coracoacromial ligament to recreate the acromioclavicular ligaments, and some would advise to have lateral 1/3 excision because acromioclavicular joint arthritis always ensues. Regarding the rehabilitation protocol, regarding the incision, it is a deltopectoral approach. Coracoid is marked and an open incision is given, and identification of the area, and the endo button is passed through the coracoid and the clavicle after reduction. The patient is advised not to do overhead activities and 9 degree of abduction. Regarding there is a rehabilitation protocol called Gladstone 4-phasic protocol. Basically, it consists of phase 1, pain control, phase 2, strengthening, phase 3, functional participation, phase 4, sport-specific activity. The complication is ACJ degenerative, and which needs distal clavicular excision. Chronic instability can happen, which also need distal clavicular excision and stabilization with a stump. Probably the name is Weaver-Dunn procedure, or for AC joint osteoarthritis, similarly, you have to do the Zanka views and MRI. For that, if there is, you can give injections. If there is still there, you can do AC joint arthroscopic or open resection called Mumford procedure. You keep superior ligaments because they are important to for stability. The superior acromioclavicular ligaments. Resect only 0.5 to 1 centimeter of lateral clavicle, and meticulous repair of deltotrapezial fascia to prevent wound dehiscence.